Hello, my name's Dr. Creaney. I'm a consultant in sport and exercise medicine, and today I wanted to talk to you about performance medicine. My background is that I trained in sport and exercise medicine in the UK. Prior to this, I was a GP up till 2006, but for the past 15 years, I've been working in sports medicine. Predominantly in the sport of track and field with the British athletics team. More recently in football, working with Liverpool FC ladies team, and currently with the British taekwondo team based in Manchester. So what is performance medicine? Well, it's the branch of medicine that focuses on optimizing physical performance. Obviously, it has a big role in sport, but it branches out into the general population also because the principles that we follow are equally applicable. So in sport, the focus is on, generally speaking, very healthy individuals and maximizing their sporting performance. We're training them to promote injury resistance and illness, and also trying to maximise the response to their training and to improve their sports performance. Occasionally, performance medicine has had some negative connotations in that in some sports it's been abused and people are being helped to cheat. So the performance medicine that I'm talking about today is definitely not how to facilitate cheating in sport, or even really getting close to the line of technically playing within the rules, but pushing things right to the limit and getting against the rules and the spirit of fair play. So sports medicine really sits at the centre of an entire support team that sits around the athlete and coach. We certainly don't work in isolation, and we're really only involved in one small part of sports performance. And really, doctors get involved much more frequently at the end of things when things start going wrong. So normal physiology, generally speaking, it's looked after by the people and the practitioners that you can see illustrated here. This is from the English Institute of Sport. And doctors really mostly get involved when normal physiology starts turning to the pathological. So looking into that whole question of what do we do when things start to go wrong. And just some general principles here. How does a human being know that they're well or unwell? We obviously have various inputs into our system on a daily basis. So on the left of this slide here, exercise, illness, infections, particularly viral, diet and stress. And all of these inputs feed into our physiological systems, our neuropsychiatric system, endocrine and immune. And all of this information is integrated together by the brain to give us that sense, if you like, of well-being. I call it the vitalostat. On a daily basis, we have that general sense about ourselves, about whether we're a well person or an unwell person. And when that's going well, all well and good. But if somebody is going in the wrong direction, we're aware of these various syndromes that different populations of people can suffer from. So in the athletic world, particular emphasis there on the overtraining syndrome, also known as unexplained underperformance. In general practice, obviously, we're familiar with the tired all the time scenario, or extreme versions of that might include ME or chronic fatigue syndrome, post-viral fatigue, for example, that we see after glandular fever, and other long-term pain conditions and functional problems. Now, in sport, we really need to understand the overload principle. If there's one thing that you need to understand about training. It's this essential principle of overload. And this is the concept that if you stretch a physiological system through training to beyond what it's comfortable with, that will provide a stimulus to encourage it to improve for next time. So the training overload pushes you into stress, the metabolic signals get thrown off, and during the recovery period, the body compensates, heals, and there's a stimulus there to enhance the capacity of that physiological system so that it's better prepared next time. So this miniature cycle that we can see here on the slide at the moment of a training overload, pushing you into fatigue, but then recovery and then an overcompensation means that you're more ready for the exercise bout next time. Now, repeated cycles of this over time lead to a generalized improvement in fitness, and that's the whole point of training, is that you improve your capacity to do whatever it is you do in your sport over time. Clearly there's needs to be a balance there between the training load and the recovery, and when things go wrong we actually get this negative situation where performance is actually going down rather than improving, and this can be because there's too much training and not enough recovery, or other factors that I'm going to go into today. So very, very important in the whole realm of performance medicine or performance pathology is identifying, preventing and treating this condition commonly known as the overtraining syndrome. So various definitions have been made of the overtraining syndrome. The neatest, shortest one being recurrent performance decrement despite maintaining the training load, or even more simply, an inability to maintain previous training and performance levels. Now, I'll throw in the caveats here of the fact that there is age-related decline after the age of 30, approximately 1% loss of endurance, speed and strength capacity per year after that age. And of course it's not aspirational, so it has to be a previously achieved level of attainment, not something that an athlete was hoping to attain but never actually has. So I certainly view overtraining syndrome as being a genuine disease-like state. In a perfectly healthy individual with no other pathology, you can still induce the overtraining syndrome. And in some people, factors and aspects of it can be irreversible, or at least linger around for a very long time after the overtraining has been removed. So there was a study known as the EROS study, and I'll go into this in more detail over the next few slides, which looked at a whole panel of endocrine and metabolic factors that can be measured and seen in people with overtraining. And it can be objectively measured in individuals and in populations. So we go to look now at the overtraining syndrome and ask, what is the pathology here? And I'm going to draw this analogous situation of starvation and famine. So the human race, obviously, for most of its existence has been on the edge of starvation. It's only really in the last century that we've been overfed. So as a result, it's developed extremely good systems to ration energy, stay alive when energy is scarce, and store it whenever possible. So it's very good at rationing energy, and I'll explain this further. So these are the kind of things that the body's doing all the time. It has a sense metabolically of the amount of energy that's being brought into the body through food and expended through physiological processes and movement. And it's able to sense through various metabolic signaling molecules whether the body has good energy stores and good energy availability, or poor energy stores. So some of the molecules, and obviously this list isn't exhaustive at all, are listed up there on the top left: cortisol, glucose, insulin, hormone levels, and then various intracellular second messenger molecules like adenosine monophosphate, kinase, mTOR, mammalian target of rapamycin. These are molecules that are produced when you exert yourself and at the end of metabolic pathways. So they're also molecules that are used to signal to the cell a training stimulus. All of these inputs are integrated in the brain. And then we have the master hormone regulator, the hypothalamus, which releases the master hormones of the body, which controls the whole endocrine tone of the body downstream. So we take, for example, gonadotrophin releasing hormone. This stimulates the release of luteinizing hormone and follicle stimulating hormone, which in turn will promote release of estrogen and testosterone, which in turn control in women the menstrual cycle, but also muscle growth, and even to an aspect bone mineralization, so calcification of the bones. Another master hormone, growth hormone releasing hormone, which in turn releases growth hormone from the pituitary, which in turn releases IGF-1, which also has a role in bone mineralization, muscle growth, and so on and so forth. When energy availability is low, the brain and the hypothalamus downregulates the secretion of these hormones, and we get a downregulation of the whole endocrine system. So if we look at these two pathways here, we've got the good pathway up top, we've got the not so good pathway down the bottom. So if we start here and we have a training session, an overload stimulus, if this is well fed and well recovered, we should get a functional response to training. We get positive adaptations, we have the fuel available to synthesize new protein and generally be anabolic. And the net effect of that training session should be a positive one, and we're creating that positive feedback loop of increasing fitness. However, the negative side of this pathway is if we were to do an overload stimulus, a training session, where we're perhaps not allowing full recovery, or we're doing it in a poorly fed state, reduced carbohydrate, protein, reduced recovery or too much stress. And then rather than getting a positive adaptation, we might actually get some protein breakdown, disrepair and injury, catabolism, and worsening fitness. And we get this negative response then to training where we actually get a maladaptive response. So this can be induced experimentally. It's certainly been done in rats. And the overtraining response to training can be induced. This was an experiment done in rats where they were overtrained, trained on a treadmill, or a wheel rather, for 35 minutes per minute, 7 days a week, 2 hours per day. And the overtraining group had their volume significantly increased, more than the control group. And we can see there after 4 weeks the physical wear capacity of the overtrained rats actually got worse, despite the fact that they were training harder than the control group. They actually reduced their fitness levels, which is paradoxical to what you would think. You would think that if you were training harder, your improvements would be greater. There is a sweet point. So what actually happens in overtrained muscle at a histological level? So this was a study actually done in humans where they again looked at and compared control sedentary and overtrained athletes, and they were actually looking histologically at the quality of the muscle. And we can see what healthy muscle looks like here. Roughly the muscle fibres are all of equal size. The nuclei of the muscle are all at the edge of the muscle, indicating that they're nice, mature, healthy fibres. As we become increasingly overtrained, we start to see changes. we can see relatively more central nuclei in the muscle, indicating that these are newer fibres, because it takes a while for a fibre to mature and for the nucleus to reach the edge. So when there's a high turnover of muscles, we see more centrally placed nuclei. Instead of the nice, neat, all equal fibre sized, we start to get variation in muscle size as it becomes pathological. And then in some even worse cases, we start to actually get cell necrosis appearing. So it's all about a very important type of cell that we get in muscle. This is essentially the nucleus of muscle cells. Obviously, muscle is organised differently from most cells in the sense that it isn't one cell with one nucleus. Instead, we have this pattern of satellite cells which contain the DNA, the nuclear material, which is what muscle uses as its source for protein synthesis from the DNA. So satellite cells generally sit on the edge of muscle fibres, and when we have injury or training and there's a stimulus to create new muscle fibres, they divide and provide the DNA and therefore the protein for new muscle fibre synthesis. These eventually fuse together and form new muscle fibres. So they're very important and a key thing to point out. So again, looking at this in a bit more detail, here we can see the difference between a healthy endurance athlete and the histology of their muscle here, and how we start to get changes of thinner myofibers, splitting and disarray in overtrained athletes. Similarly, there are changes also at the neuromuscular junction with disarray, and obviously any damage to nervous tissue is much harder to regenerate from and recover from, and can be semi-permanent. So there are aspects of overtraining that can lead to permanent changes in muscle and neuromuscular junction histology. And looking at DNA and growth factor expression, again, changes in the express forms of the myosin heavy chains and so on and so forth, and evidence of reduced release of IGF-1, also known as mechano-growth factor. So one of the central pathologies, therefore, that's being identified in the overtrained state is this reduction in the capacity of muscle to generate new muscle fibres via a mechanism of reduced satellite cell population. So in very severe cases, exercise-induced myopathy and overtraining can be a semi-permanent state, or at least take many months to recover from and heal from, if ever. So, going to start looking at some of the clinical factors here. Overtraining syndrome is obviously more common in sports that require a high volume of training. You can see here the relative prevalence it's very common in the running sports and also rowing and swimming, where there is a very high volume of training. We see it a little bit in CrossFit as well, and we'll come back to the Eros study in a minute. As you get down to sports that are less involved endurance and high training volumes and are more skill-based or speed-based, the frequency of the overtraining syndrome does start to fall off. So, diagnostic criteria for the overtraining syndrome. There's a few exclusion criteria. Obviously, you couldn't diagnose it if somebody was deliberately losing weight and on a hypocaloric diet. Objectively, there should be a difference of at least 10% performance loss before and after. And it should be prolonged. Generally speaking, at least 2 weeks, preferably 2 months. for it to be considered pathological. We see changes in things like the profile of mood scales, POMS questionnaires, and also other self-reported aspects of well-being. There's often mention of decreased sleep quality, and we'll go into this more as well. So I want to do quite a bit of attention on this really good series of studies that came out a couple of years ago, the endocrine and metabolic responses in overtraining syndrome, or EROS studies. Now what they did in these studies at a population level is they measured an entire battery of endocrine and metabolic tests, and they were able to discern differences between in this particular study it was CrossFitters who were in an overtrained state versus CrossFitters in a healthy state, and non-physically active controls. So that's your three categories here. Now some of the traditional things that we measure, there wasn't really a clear delineation or cut-off between the different groups. So for example, if you were to just measure serum testosterone levels, you wouldn't be able to at population level or even in individuals define a cut-off between overtrained people and healthy people. But we do see, for example, changes in TSH. So overtrained CrossFitters here with a TSH slightly rising to 2.4 versus 1.8 in the healthy controls and in the untrained group. And then things that are a bit more difficult to measure but can be done, like 12-hour urinary catecholamine secretion, and again a clear difference between overtrained individuals and the healthy controls. I'm picking up on one catecholamine in particular, noradrenaline. And then if we look down here, again, things like the testosterone to estrogen ratio, you can see a clear difference between the overtrained group and the healthy controls, which were again more comparable to untrained individuals. But interestingly, not necessarily a difference between the testosterone to cortisol ratio between different groups. Further tests that were done, some of the more traditional endocrine stimulation tests like cortical response, not really showing a statistically significant difference between groups. But if we look at the ACTH response to an insulin tolerance test 30 minutes after hypoglycemia, a clear difference between groups again. So these tests can be done in clinical practice. Some of them do take quite a long time to do. Most endocrine stimulation tests do involve a short stay on an endocrinology unit to do the test over a few hours. And some of them are simple blood tests that you can do in the clinic setting. So the EROS study evaluated hundreds of different markers and it rejected the vast majority of them because there wasn't a discernible cut-off between normal controls and overtrained. But these ones here seem to have the best diagnostic utility and are being investigated further in terms of their use in clinical settings. So noradrenaline secretion in the urine, testosterone to estradiol ratio, ACTH response to an insulin tolerance test, estradiol levels, and then things like fatigue on the profile of mood scores subscale and rating of libido. So you can put these together and you can do a very simple score, non-clinical, not doing any blood tests, so looking at eating patterns and the profile of mood states questionnaires. Or you can do more complete testing and as well as adding in the questionnaires, look at these hormonal challenge tests and resting levels, and even looking at body composition. So the EROS study, sorry about the smallness of this slide, but looked at the factors and, in a sense, the pathway leading from normal physiology to an overtrained state. And they identified low protein intake and low carbohydrate intake, leading to chronic energy depletion as a big factor. Excessive training, unrefreshing sleep, and excessive stress. These inputs leading to maladaptation over time and triggering pathways like increased catecholamine secretion, leading to a hyper-aroused but fatigued state. And the consequences, obviously, that we know of physical fatigue, central fatigue, loss of performance, and a generally hypometabolic state with downregulation of all of the master hormones. So the Eros Complete tool, you can see it's quite a battery of tests that you would need to do, quite expensive to do to an individual, and most of the time you wouldn't need to go to these lengths to be able to diagnose somebody as being overtrained. But you do all of these tests, you get a score, and then when you come to your complete score, depending on what it is, you can either exclude the diagnosis of overtraining, it would be inconclusive, or a definite case, depending on how they score. So I'm going to move off overtraining syndrome now to look at overtraining related injuries. There are many pathological states where overtraining is a factor, if you think about it. So exercise-induced asthma, for example, increased ventilation rates of cold, dry air are implicated in airways inflammation. We definitely see in ultra endurance runners and people who've been running for many years evidence of cardiac fibrosis, which can be implicated in arrhythmias like supraventricular tachycardia. Tendinopathy, clearly a big factor there is the balance between training stress and recovery, and similarly bone stress injuries and stress fractures. And I do wonder sometimes when people get these spontaneous ligament ruptures whether there was a painless ligamentopathy in the lead up to this. Obviously not many neural fibres within ligaments to know whether it was painful beforehand. And then in older runners, for example, we start to see intrameniscal degeneration, which eventually reaches an edge and becomes, for example, a degenerative tear. And obviously, adding into all of this, in terms of energy metabolism, we have the overtraining syndrome. So for me, for every acute injury that exists within a musculoskeletal tissue, there's probably an analogous overtraining equivalent injury. And for me, if muscles have acute tears, for example a hamstring tear, the analogous overtraining injury is the overtraining injury that I've just shown you on those histological slides in muscle, and so on and so forth for bone, tendon, ligament, and probably cartilage as well. So if we think about tendons, for example, this is how overtraining can be implicated in tendinopathy. We know that the training stimulus provokes protein synthesis. This peaks after about 24 hours in tendons and continues, you can see, into 72 hours. But there is also damage that comes through training, and this perhaps peaks a little bit later in tendons. And we can see that at 36 hours, that balance between protein synthesis and degradation may still be quite negative. So maybe that tendons need that slightly longer recovery of 48 hours in the long term to maintain tendon health. And this is a factor to build into training schedules. And we're all very familiar, I'm sure, with the Tim Gabbett philosophy of monitoring that acute to chronic workload ratio. And we get sudden spikes of increased acute workload. against a background of lower chronic workload. This is when the body often can't handle it and we fall into that injury risk zone. So it's therefore really obvious that through careful monitoring of training load and recovery, we can prevent people getting into those dangerous overtrained zones. So this next section really is looking at prevention. It's monitoring that physiological and psychological wellness in teams and athletes. And certainly there's evidence from lots of sports now that with careful monitoring you can prevent athletes from slipping into that overtrained state, and prevention is definitely better than cure. So again, coming back to the EROS study and many other studies, key faults that have been identified in training schedules that do lead to overtraining would be rapid increases in training volume. So good examples of that would be going away for a week for a training camp where you suddenly train much harder than you have been doing previously. Lack of recovery, both on a day-to-day basis but also on a chronic basis. And increasing the amount of training to greater than 10% of a 24-hour period. So, for example, in football, it's rare these days for the daily training session to go into 2 hours. They usually keep it shorter than that. And as always, the decrease in physical work capacity is the universal finding that we're trying to monitor for. So this is an example of some of the readouts that we would get in football. This is from Liverpool women's. Obviously in football now everybody wears GPS monitors which track their movement both in the training sessions and in the games. So in a typical training session we can monitor the total distance ran for every player. We can look at things like high speed running distance, so how much sprinting they've done within that running. We can look at the sprinting distance, and we can look at the top speed that they've hit in meters per second. And we can also look at other things that may involve injury risk, like how much high intensity acceleration and deceleration and change of direction that they've done. And obviously this implicates in things like groin injuries as well, and other injuries that change of direction can be a factor for. And now we can even put monitoring on the boots to see how many times they've kicked the ball and how many passes that they've made. So we can very intensively monitor the training load across the course of a day, a week, a season, and we can also use these measures to see when people are dropping off their normal curves. There is even more detailed monitoring that's available. You can look at heart rate variability, which is an index of cardiac health. It's normal for there to be a significant beat-to-beat variation in the R-to-R interval. And this is a reflection of the balance in the autonomic nervous system between sympathetic input and parasympathetic input. Obviously, sympathetic input from adrenaline is the stress or fight or flight response. This would be a tendency to increase the heart rate, and then the beat-to-beat variation gets smaller. When you're in a more relaxed recovery state where there is parasympathetic nervous system predominance, obviously the heart rate goes down and there will be more beat-to-beat variation. And again, these monitors can be used to track somebody over the course of a day, so they can be worn over the 24-hour period to see when somebody's heart rate variability is in a relatively stressed state when they're training, and also how well they're recovering. And then obviously you can assign a colour to this, red to indicate levels of stress and green to indicate recovery, and obviously monitor people's sleep and recovery and make sure that they're not spending too much of their 24-hour period in a stress state versus a recovery state. So arbitrarily, you can assign what's considered good heart rate variability and beat-to-beat variation and poor. Thing to point out here is that heart rate variability does tend to decline with increasing age, so you need to adapt that to your older athlete. There's other monitoring methods and devices that can be used. For example, it's quite common now in teams to do daily wellness monitoring. So getting up in the morning, they're asked to fill out these charts online, or they can be put into an app. And again, you can score their mood, things like this, muscle soreness, how they rate their quality of sleep, and their general vital feeling. And again, this can be quite a good and sensitive marker for picking up on the overtrained or unwell athlete, and perhaps reduce their training for that day. And obviously there's many of wearable devices these days. Obviously the Apple Watch can monitor sleep. More sophisticated devices like this wearable Oura Ring, and again this can measure sleep quality. Just to mention a couple of factors in relation to junior athletes and any kind of special considerations there. So obviously there's additional calorific requirements in growing athletes because they want to grow as well. Obviously they have a huge regenerative capacity, so we're able to recover from training and train on a more frequent basis. But overuse injuries, whereas we see stress fractures and tendinopathy in adults, what we're looking out for in junior athletes as well is things like growth plate injuries and apophysitis, so things like Osgood-Schlatter's, Sever's disease, so on and so forth. They often also have the added stress of schooling that we need to be mindful of when we're considering our training plans. Other things that I notice with junior athletes is they can often be competing for multiple teams, their own school, county, and then even national or professional teams. And then there's the child protection issues to consider as well. There can be bullying and coercion from parents and coaches. And an interesting statistic that came out from athletics a couple of years ago is this whole issue of the poor transition from juniors to seniors. Juniors who represent Great Britain at international level and get a vest, interestingly only a third of them actually go on to do a PB as a senior and represent Great Britain. So 2/3 actually peak as juniors and never improve as a senior, which is quite staggering really. And it's probably because of a number of factors, one being that people give up because they're used to improving year on year as a junior and being the best, and then they get into a much tougher category of seniors and the success isn't there. But many of it will be down to poor management of the athlete and not being well looked after as a junior, getting a chronic injury and not being able to come back for it. Considerations in masters athletes. This was a nice publication which came out of Manchester Metropolitan University, Strong and Balanced Training, so I'd recommend you to go onto their website and just download that if you're a masters athlete. But obviously what we're dealing with over the age of 30 really is age-related decline in muscle loss. So strength training, relatively speaking, becomes more of an important factor in older athletes because it tends to be something that's harder to get back. And unfortunately in masters athletes, central nervous system degeneration seems to be the one thing that is irreversibly declined. Through good training, generally speaking, masters athletes can maintain a good level of speed, strength and flexibility. But things like balance in studies have been shown to decrease no matter what input is given. So neural training, balance training, again very important in masters athletes. These charts here just track the performance levels of Masters athletes. I got these from the Power of 10 rankings for the different age groups, and what we can see is that very approximately from the age of 30, speed drops about 0.5% to 0.75% per year. It's relatively well maintained until the age of 80, and then there's a very sudden drop off. We see a similar picture in endurance capacity. Again, there's about a 1% drop off per year after the age of 35. So endurance athletes don't seem to decline as soon as speed athletes, but again, that very sudden decline that seems to happen from the age of 70 onwards. And then just finally, in terms of strength and power, again, we can see people tend to peak around the age of 30 or late 20s. And there's again that approximate 1% fall per year after that age. So just summarising that in Masters athletes, is that we're seeing somewhere between a 0.5 to 1% decline in those physical parameters per year from the age of 30 to 35. So there could be an argument there for making Masters sport from the age of 30 onwards rather than 35. Certainly the World Masters Games is from the age of 30, but other sports don't start till 35. So there's that 5-year window where people maybe aren't competitive against their peers, where there could be a huge dropout and people are lost from the sport. Maybe they would stay in the sport if the Masters categories started at the age of 30. So just one other consideration in Masters athletes. This was a nice study that came out of California, the TOM trial, where they did use anabolic steroids in the elderly to maintain muscle strength, and very clear gains from testosterone supplementation there. And it did depend on the dose as well, increasing doses of testosterone leading to increased gains in the leg press, 1 repetition maximum. Now obviously this does have an implication in Masters sport because testosterone is obviously a prohibited substance, and testing does go on in Masters sport, but from time to time doctors do get asked to prescribe testosterone if serum testosterones are below age reference values and people have symptoms of tiredness and fatigue. This, generally speaking, obviously isn't possible in Masters athletes because you wouldn't get a therapeutic use exemption passed for this. And just to point out again that testosterone levels do decline with age, so it has to be measured against age reference values. Other special populations that we need to consider, menstrual problems can be obviously a big issue for women and can affect performance. Performance is very definitely known to vary throughout the menstrual cycle, and obviously athletes need to be aware that having a regular menses is a sign of good health, and that missing periods generally speaking indicate low energy availability and are a sign of poor health. And athletes who are presenting with this need to be investigated for relative energy deficiency in sport, but also not all secondary amenorrhea needs to be in athletes should be automatically considered to be functional. There may be an underlying medical disorder and it does need investigation. Dysmenorrhea obviously can be a real performance issue and needs treating. It can often respond to the oral contraceptive pill or non-steroidals, and obviously there's other treatments available. If it fails to respond to simple treatments, it does require investigation, and potentially there are referral pathways into obstetricians and gynecologists, and there are specialists who take an interest in female athletes in the obs and gynae world. Okay, going to move emphasis completely now and start looking at diet. and what we might consider to be a performance diet. So obviously the traditional sort of Western sporty healthy diet would be considered to be low in saturated fat, moderate amounts of polyunsaturated fat, which obviously increase HDL cholesterol, carbohydrate, protein, your 5 a day fruit and vegetables, and plenty of variety to avoid monotony and to make sure you're getting a good balance of micronutrients. And this is all kind of summarised in the Eat Well plate here, which shows you a rough balance of the different foods that you should be getting in a healthy diet. Now, if we contrast that against diets that we get in other parts of the world, ugali would be the main staple diet of Kenyans, for example, and they would eat this for breakfast, lunch and dinner. Eliud Kipchoge there, the world marathon record holder. It's a food that's based on maize flour. It's got a good balance of nutrients in it. It's low in fat, high energy content, carbs, fibre and protein with a little bit of iron, and they tend to eat this mixed with meat and vegetables. It's a very low variety diet. It's quite monotonous to be eating the same thing meal after meal. But it's been very successful, as we can see. Most of the world records in endurance events are held by East Africans. They have, essentially a monopoly on all records from the 800 metres upwards. This is the men. And an almost total monopoly on the world records in women's events as well, coming from Kenya, Morocco, Uganda, Ethiopia, etc. So the point I'm making is the commonly reported Western diet, which we use here, there are alternatives to it which can be very successful as well. Now, body mass index is often knocked in sport and said to be not valid. I don't necessarily believe that. I think BMI is an important measurement. This study looked at BMI in Olympic athletes, male, across different running distances. And what we can see here is that BMI is very tightly clustered in different distance groups. So if we look, for example, at marathon runners, this is elite Olympic marathon runners, we can see that the most common BMI in elite marathon runners is sitting around that sort of 19, 20 level. And then it's very difficult to be an elite marathon runner if you get further and further away from that optimum BMI. So very, very thin runners, we can see very few manage to reach optimal levels, and again very, very heavy runners, very few of them manage to be elite. And if we go right down to the other end of the spectrum and look at the 100 metres, we can see the optimum BMI much, much heavier in 100 metre sprinters. And we can see the median there sitting around somewhere around 24. And again, it's very, very uncommon for 100 metre sprinters to be exceptionally thin or indeed exceptionally heavy. And we can see that all of those curves are roughly normally distributed. And I've just chosen the red line here, which corresponds to the 1500 metres, and we can see if we drop that down, there does seem to be a optimum BMI that male 1500 metres cluster around, and it's around that 21 range. Harder to get those same stats for women, but there was a large pool of data extracted at the London 2012 Olympics where they measured the heights and weights of all athletes at the games, and they actually published that data, so you can download it and analyse it. So again, when we look at female heights, weights and BMIs, we can see the same general pattern, that in the marathon they tend to cluster around quite low BMIs, but still within what would be considered the healthy range, 18.6. with an average weight of about 49 kilograms, and then a general increase in the BMI and weight as we get to the shorter and faster distances. And if we look at female 400 metre runners at the London 2012 Games, they were clustering around that BMI of about 21 with an average weight of 66 kilograms. Obviously, this is something that's even more important in make-weight sports. So in particular, the fighting sports like boxing, taekwondo, the sport that I'm involved in. The tendency in these sports is people like to sit heavy for training because it makes them feel more energetic. And then they tend to lose weight prior to competition to make weight for their category through a combination of calorie restriction and also dehydration. Obviously, putting yourself into negative energy balance for a prolonged period of time and that low energy availability state is going to make you feel fatigued. So there's the constant debate there around how heavy people should sit outside of their weight category and how much weight they should be losing. So we can use DEXA scans to get a very accurate measurement of an athlete's weight, BMI, lean mass and body fat percentage. And certainly in the sport of athletics, we know that elite male athletes will sit around that 10% body fat or less level, and elite female athletes in that 10 to 15% range. And typically these readouts give you these measurements in a nice graphical form. So what about micronutrients and hormones? We monitor these because we know various ones have an important role in energy metabolism and performance. So probably the biggest one here would be iron. And we know for sure that iron deficiency very definitely impairs aerobic performance. Certainly in elite Olympic level athletes, we screen for this on a regular basis. We'll check their hemoglobin and their ferritin. And we like to keep those iron stores, those ferritin levels, at least 30, if not preferably over 50 in elite athletes. Iron isn't well absorbed if you take it on a daily basis. It leads to release of proteins that impair iron absorption. So it's actually been discovered that it's better to take iron on a alternate daily basis because it actually maximizes absorption and use. Take it alongside calcium to maximize absorption and try and get as much of it in forms of natural iron from the diet rather than supplementation. Some athletes, no matter what you do, you cannot get their iron stores up and they may need intramuscular or intravenous iron infusions. Vitamin D, very popular and well regarded now as a performance parameter. It's normally low in winter due to low sun exposure, so we do tend to again screen for this a couple of times a year. Vitamin D is important. There are vitamin D receptors on muscle and it does have steroid-like actions, and we know if people's vitamin D gets very low, they start to get weak bones and muscle aches and weakness. So we generally speaking in Caucasian populations check the vitamin D. It may be important in Asian and Afro-Caribbean populations. It's been identified that you may need to also check other metabolites of vitamin D to get a true understanding of the vitamin D levels. Okay, so this is an example of a treatment protocol. This one's from the English Institute of Sport for vitamin D supplementation. And this just gives us a rough guide as to how we should be supplementing people based on their vitamin D concentrations. So you'll see if people have got very low vitamin D, then we generally supplement with 4,000 units a day. You can even go higher. Some athletes you can give 20,000 units on every third day or 100,000 units a week, for example. But this would be adequate for most people. Magnesium's another very popular supplement. As always, you should try with elite athletes, well, always with elite athletes, get from a batched sourced company. Magnesium's an important micronutrient. There's no point measuring serum magnesium really, because it fluctuates up and down during the day. Goes up and down in response to exercise, for example, and levels of hydration. So if you want a true reflection of whole body magnesium storage, you need to check whole blood magnesium or the red cell magnesium. There's no point supplementing magnesium to supra-physiological levels, as this in itself can be harmful, so the aim is just to get magnesium in the normal range. There is evidence that it can help muscle recovery and improve muscle power production. Very occasionally I've needed to give intravenous magnesium to athletes when it's low. Very contentious issue here, thyroid hormone and replacement. Obviously, this was well spoken about in relation to the Oregon project and Salazar and the Texas endocrinologist who had a very low threshold for putting people on thyroid supplements. It is a matter of debate. It's not clear cut. And some people would advocate supplementing with levothyroxine to keep a TSH below 2.5. Most labs would put that normal range for TSH in the 0.5 to 4 range, and would only put people on supplementation if the TSH was going above that, or if there was other biochemical evidence that thyroid hormone was low, the free T3 and T4, or actual clinical signs of hypothyroidism. So when we're screening athletes for overtraining syndrome, it's good to look at the training diary to see what their usual load is. There needs to be an assessment of their diet, the calorific intake, carbohydrate, total energy and protein in particular, and also the balance of nutrients. Sleep obviously needs to be looked at, the amount of recovery. Big difference obviously between people who train every day and those who have rest days. Looking at levels of psychological well-being, stress, depression and other things going on in an athlete's background. Libido, the sex drive, has been obviously very clearly identified as something that goes off when somebody's overtrained. And also the presence of any concurrent medical illnesses. So, moving on to talk about some supplements now that are popular. I'm not going to talk about every single supplement under the sun, but some of the more popular ones in sports medicine circles at the moment. Very important to point out that any supplement carries a risk of a positive drug test. A lot of supplements aren't made in pharmaceutical standard labs and contain contaminants, especially if other products are being made in the same factory. So you do have to warn all athletes that there is the principle of strict liability. Whatever ends up in your body, you are responsible for. It doesn't matter how it got there. So that you do take supplements at risk of a positive doping test. To try and mitigate that, we try and get all supplements from batch tested sources, and always any drug or supplement that an athlete's taking, we encourage to look up on Global Dro in the UK. So of course there's many supplements out there, and some of them do have reasonably good levels of evidence. These ones listed here. Some of these are for acute use, so for example sodium bicarbonate is obviously a very short-term use over the course of just an hour really. Be very effective in middle distance races. Obvious side effects gastrointestinally from that. Caffeine, which is obviously only useful on the day, creatinine, which is useful for recovery but tends to cause weight gain and water retention, and beetroot juice again being shown to improve endurance. So beetroot juice, I'm talking about first. It's high in nitrates, NO3 species, which in itself is a nitric oxide donor and a vasodilator. And there's certainly evidence from beetroot supplementation of improved endurance and also particularly high intensity work done over 80% of VO2 max. Different studies have used different supplementation strategies. So a common one would be to have about 200 mils daily for a week, or an acute dose of 500 mils 90 minutes before a race. And this has been reasonably well studied and is generally well accepted in sporting circles these days. Another really common supplement that's seen now would be various concentrated cherry preparations, obviously an antioxidant, and again some evidence in recovery for reduction in delayed onset muscle soreness and potentially even improved endurance. And again, these cherry supplements have been reasonably well studied now. There's a reasonable body of literature to support their use. In terms of injury prevention and treatment, of particular use in tendinopathy would be collagen combined with vitamin C to improve absorption. It's very expensive stuff though, collagen, so a cheap man's collagen would be gelatin, which is just broken down collagen. So this is the kind of stuff that you make jelly from. So simple gelatine that you can get from the supermarket, and it's what's in things like wine gums, Percy Pigs and the like. If you co-ingest collagen with vitamin C, it is absorbed better. So again, this has been studied in a few different papers, and in particular in relation to Achilles tendinopathy treatment. The theory being, of course, that if you increase the amount of available substrate for repair of tendons, which obviously are made from type 1 and 3 collagen, then you can improve recovery and healing. So in this particular study, they used a collagen supplement and compared it against placebo and had good improvements in pain scores. You can see here the response in terms of VISA-A at 3 different time points. And even in terms of return to running. So anyone with tendon problems, this is potentially a good supplement to use after training sessions. The other important thing, obviously, in tendon problems is to try and avoid non-steroidals, which will block the good inflammation that's required after training and has been shown to completely obliterate collagen production post-exercise. So anyone with tendon problems, you should actually avoid non-steroidals. I know that's against the received wisdom, but that's what the studies have shown. Another really popular supplement these days, lots of people mentioning this with respect to joint pains and arthritis, is turmeric. It's essentially a spice. Has anti-inflammatory properties, has been shown to reduce CRP levels, and one of its metabolites involved in cartilage formation, so potentially good for joints, and has been shown in some studies to reduce pain in arthritic joints with relatively few side effects. Okay, so I'm going to move on to the final section now. We're sort of 80% of the way through the talk to look at how we investigate fatigue. Just going to refresh again about the nomenclature that we use in overtraining here. So obviously people initially present with symptoms. We can call this unexplained underperformance syndrome, which is a UK term. It generally speaking is called overtraining. In other circles like the USA, the Antipodes and Europe. Obviously we investigate people because we try to find a cause. We can make a positive diagnosis of overtraining syndrome. Obviously we use that EROS panel of tests, so it's not just a diagnosis of exclusion, but obviously we're screening for other conditions that can cause fatigue as well. So obviously if we make a diagnosis, then unexplained underperformance should become explained underperformance. But if there's no other medical disorder, this is what we consider to be the pathophysiological state known as the overtraining syndrome, or the overtraining injury as it relates to changes in muscle structure. So obviously there's innumerable causes of fatigue, too many to mention. Just highlighting some of the more common ones here, and obviously one way to think about this is to split it up into older and younger people, but obviously there is huge overlap even then. But in younger people, what we're tending to see is the genuine overtraining syndrome. Iron deficiency obviously really common, and other nutritional deficiencies, but don't forget about things like diabetes, first presentations, underlying cardiac disorders. So many athletes haven't been screened and there may be an underlying HOCM or something like that. Glandular fever, Epstein-Barr, obviously common in younger people. And then cancers that can present in young people, and obviously these days COVID as well. Older people, we can't discount the effect of aging and sarcopenia obviously, and some people just have unrealistic expectations about what can be achieved with advancing age. But other things that we need to look for is around thyroid, cardiorespiratory problems, chronic disease, cancer, and just about anything. So we don't do this too often in athletes, but if there's a question around whether a person's fatigue may be cardiorespiratory rather than metabolic, you can do cardiopulmonary exercise testing, and depending on the results, this can give you an idea if there is some degree of cardiac output issue, or whether there is a respiratory ventilatory limit on performance. And this chart here also helps you differentiate between poor effort and deconditioning and those things as well. So people often ask about a blood test to tell them why they're tired. Some patients seem to think that there's one single blood test that doctors can do which gives them all the answers, and often don't appreciate that there's 1,000,001 blood tests that are potentially possible to do. But as a general standard as first screen, these are the kind of tests that we're going to do. Obviously full blood count and ferritin. When these are done privately, I put an indicative price list next to the tests. We can see that the costs do go up quite quickly once you start getting a lot of different blood tests done. Vitamin D important to test, vitamin K sometimes involved in vitamin D metabolism, thyroid function obviously, a quick screen for diabetes, magnesium, testosterone, in women the sex hormones, and probably worth screening for underlying disease as well with a CRP and an ESR. And then really depending on the history, the examination, the age, the initial findings, you need to target further blood tests depending on what you feel the underlying issue could potentially be. Obviously you can test for the vitamin B hormones, screen for celiac disease, look for any kind of rheumatological disorder. Sometimes it's important to screen for HIV and other viruses. Sometimes underlying allergy can cause issues. Heart failure in older people, checking the BNP, and again doing tumour markers for screening, and even a myeloma screen. One of the big issues obviously with doing blood tests is you can sometimes open Pandora's box. So the more tests that you do, the more likely you are to find an abnormality. The abnormality may or not actually be relevant. It might just be something that's outside of the normal range and it takes you down an irrelevant rabbit hole or causes unnecessary distress and investigation. So really be aware and counsel patients that if you're going to start down on the investigation route, it can often be very open-ended and you don't necessarily know where it's going to lead to, and you can really open Pandora's box sometimes. So moving on to a new section around recovery. If somebody is diagnosed with the overtraining syndrome, what strategies do we have to get them back into fitness? So coming back to the EROS study, all of these different things were used to predict risk of developing the overtraining syndrome. And these were some of the treatment strategies that were recommended, and I'll just finally go over these in the next few slides. So obviously modifying training, really important, and the recovery, optimizing sleep, and really importantly optimizing diet, making sure that there's adequate energy coming in, so total carbohydrate and energy intake, but also sufficient protein intake for tissue synthesis, and then reducing stress and external workload as much as possible. So these are the sort of recommendations that can be given and need to be looked at to see that athletes are meeting them, making sure there's that high protein intake, high carbohydrate intake, reducing other stresses in the life, and promoting good sleep. And just in terms of nutrition, as well as getting your 3 good meals in per day, before, during and after sessions itself, there's that golden hour after training where the muscles are somewhat glycogen depleted, is that golden hour to get carbohydrates in. So it's often good to take an energy drink as soon as possible after a training session. In terms of graduated return to play, we do talk about this 10% rule of not increasing volume of training by more than 10% a week, or intensity for that matter, allowing full recovery in between sessions, and manipulating the 3 factors that we manipulate in training: volume, frequency and intensity, and not increasing more than one of those factors at once. Reinforcing the message really that Rome wasn't built in a day, that fitness is a lifestyle. It takes a long time to accrue small marginal gains. It's not possible to suddenly get fit or faster in the space of a few weeks. This is a really good example of how Paula Radcliffe's running economy increased over the course of several years. Her actual VO2 max was fairly constant, but her running economy at racing speed got better and better and better, to the point that she was able to break that world record. But that was a running economy improvements that happened over the course of a 20-year career. Obviously COVID's an issue now, and we've now got written guidelines for return to play following COVID. So these are the different stages that people go through, and we can see 10 days minimum following COVID, followed by 2-day stages, 1-day stages, and so on and so forth. And this has been written up and published in the British Journal of Sports Medicine. Sleep, we've mentioned, is really important. Particular emphasis on children. The American Academy of Pediatrics recommends that young children need to get 9 to 12 hours of sleep per 24 hours, teenagers 8 to 10. But what we do know is that young athletes obviously often have very poor sleep. So sleep hygiene is really important. All the usual rules, I'm sure most GPs know what these are. Going to bed on time and getting up at the right time and trying to aim for those 8 to 9 hours. avoiding blue light and screens in the hour before bed, and other things which we'll come on to. Caffeine is one of the big issues, particularly in footballers, I've noticed. They take loads of caffeine before games, and games are often quite late in the afternoon, not finishing till 5 or 6 o'clock. And then obviously they're struggling then, they're completely wired, not just with caffeine but with the adrenaline of the game as well, and often can't get to sleep until very late the night before, so we do try and limit the caffeine consumption. And just some additional sleep hygiene recommendations here. Obviously you'll have to freeze the video to read through these fully. There are some dietary things that can promote sleep. It's said that foods high in tryptophan can promote good sleep. Some examples, probably the most commonly recommended one would be a warm milky drink. And obviously there's foods that are shown to interrupt and lead to poor sleep as well. Caffeine and alcohol being the main protagonists there. Blue light coming through from screens, but also anything that might cause indigestion or fatty foods with prolonged gastric stasis, so on and so forth. It's a common problem as a team doctor to be asked by players for sleeping tablets. We really need to avoid that at all costs, because as we know, they lead to dependency. Increased doses are required and they lose their effectiveness over time anyway. So as an alternative, we try to offer melatonin and good sleep hygiene and resist at all possible using the Z drugs or benzodiazepines. If they are given, they're normally on a limited prescription. I tend to not give out more than 7 days at a time and then enforce a break. Other recovery methods in relation to performance, massage, obviously a mainstay in the elite and professional sport world. How does massage work? Not a lot of research on this, but massage is believed to activate various mechanotransduction pathways, and certainly some studies have been done where biopsies have been taken of massage muscle showing reduced levels of inflammation, and also subjectively reduced pain and perceived fatigue following massage. And certainly in rat studies there's even evidence of enhanced muscle growth. But one little caveat there is that it's maybe not great to have a pre-race massage, because some evidence that it impairs sprinting and power. Cold water immersion, ice baths, again another very popular trick of the trade in the elite sports circles. Proposed mechanism, as you can see there, is vasoconstriction, reduce muscle blood flow and inflammation. Really the leading papers on this were done by Jonathan Leader at the English Institute of Sport, and there is certainly evidence of improving some aspects of recovery. What's important about cold water immersion, however, is that this really is a method only used during competition. If you're doing this all the time, you're obviously reducing the inflammation that you need to have a positive training effect. So you wouldn't be doing this all year round in training sessions. This is very much a method used for acute recovery during competition itself. So we're at the end here, putting this all together. So we've seen that there's multiple different aspects in relation to performance and recovery and injury prevention and treatment. If we were to consider a hamstring muscle injury, for example, we're not just talking about the basic muscle injury and rehab, but we've got to consider the neural factors, nutrition, biomechanics, fatigue, previous injury, strength, factors like that. And indeed, all of these other things feed onto that. We're looking at supplementation in the diet, recovery, protein, changing things like the fascicle length to make them more injury resistant, eccentric work, reactive strength, and various supplements that could be used to enhance recovery and performance. So I'm just going to finish here with this final quote from Albert Einstein, is if you keep doing what you're doing, you'll keep getting the results you've been getting. And this really is a push in the elite sport world that we have to constantly be innovating and discovering new things to get that edge. Sport is always moving forwards, and if I was to do this talk in another 10 years, the content hopefully should be completely different. So thanks for listening today. We're on 80 minutes there. My name is Dr. Leon Creaney. I'm a consultant in sport and exercise medicine, working privately in Manchester and also in elite sport with athletics, football and taekwondo. And there are my details there.